this episode, I'm going to be talking about history of hormone replacement therapy for menopause, from enthusiasm to evidence. Very few therapeutic areas have experienced as dramatic a trajectory as hormone replacement therapy for menopause, swinging from near universal prescriptions to widespread abandonment, and now towards nuanced, evidence-based rehabilitation. The history is very interesting. Understanding this history is essential for clinicians and patients navigating the ongoing debates and outcomes. First, the early origins, that was early 19th and early 20th century. The concept of a missing factor in postmenopausal women dates to the 1800s, when ovarian tissue extracts were used experimentally to reverse menopausal symptoms. For cost savings, they used conjugated equine estrogens that were derived from the urine of pregnant mares. It was developed in the early 1940s and aggressively marketed for vasomotor symptoms in postmenopausal women. This became the foundation of what we know now as Premarin. Then came the feminine forever era from 1960s to 70s, fueled by a popular 1966 book proposing that menopause was a hormone deficiency state causing loss of sex appeal, I have to roll my eyes, and youth, combined with the feminist movement. It exceeded 50 million prescriptions annually in the United States alone. By 1970, however, the tide started to shift when several studies demonstrated an increased risk of endometrial cancer with unopposed estrogen therapy, prompting a significant reduction of hormone therapy use. Then came renewed confidence with combination therapy in 1980s and 90s. In the early 1980s, recognition that adding a progesterone to estrogen therapy mitigated the endometrial cancer risk led to the development of combined estrogen-progesterone therapy. By 1990s, the American Heart Association, the American College of Physicians, and American College of Gynecology all agreed that estrogen was an effective shield against both osteoporosis and heart disease in older women. Premarin became the best-selling drug in the US in 1992. Then came WHI in 2002. In July 2002, the WHI Data and Safety Monitoring Board halted the combined estrogen and medroxyprogesterone acetate trial because risks, including invasive breast cancer and cardiovascular events, appear to outweigh the benefits in the enrolled cohort of women aged 50 to 79. The consequences were immediate. HRT use declined by almost 50% within 6 months of the study's publication. This was outrageous. It was sensationalized news of that time, and also wrongly interpreted. Most recently, from 2003 to present, we have gone back and reassessed. We've come up with something that's called timing hypothesis. Critical methodological flaws in the WHI were subsequently identified. Most noticeably, the study had exclusively enrolled women who were on average 10 years postmenopause, with a mean age of 63. A demographic already vulnerable to cardiovascular issues, and evaluated only one delivery method. The timing or window hypothesis emerged. Women closer to menopause initially have meaningfully different benefit-risk profile than those initiating therapy later. The most recent WHI analysis suggests that when HRT is initiated within 10 years of menopause, it reduces all-cause mortality and risk of coronary artery disease, osteoporosis, and dementia. After 10 years, the beneficial effects on mortality and coronary artery disease are no longer apparent. Then the regulatory developments in 2025 and 2026. In November 2025, HHS and FDA announced steps to remove or revise boxed warnings on some menopausal hormone therapy products, updating label language to remove references to risks of cardiovascular disease, breast cancer, and probable dementia, which is a landmark regulatory shift reflecting over 2 decades of post-WHI evidence accumulation. In 2026, the FDA formally removed the warnings of cardiovascular disease, breast cancer from even the menopausal hormone therapy products. The Key clinical takeaways from this talk are that history of HRT illustrates how a single landmark trial, when misinterpreted with significant population limitations, can reshape prescribing patterns for decades. Current evidence supports nuanced, individualized HRT for symptomatic women under age 60 or within 10 years of menopause onset or perimenopause onset, with formulation, with route and duration tailored to each patient's risk profile. The damage to public and clinical confidence has been slow to reverse. It's a moral obligation to counsel patients and educate women using the full weight of contemporary evidence that we have now. Thank you.